Iftekhar Alam from home and abroad, and today I'm going to talk about iron deficiency in heart failure. Time to take it seriously. Taken from the cue from ESC guidelines, iron deficiency is an anemia common in patients with heart failure. Being the independently associated with reduced exercise capacity and recurrent heart failure hospitalization, right, high CV and all-cause mortality. The ESC have defined iron deficiency in heart failure patients as such, that is, serum creatinine concentration less than 100 nanogram per ml or 100 to 200 nanogram per ml with transferrin saturation less than 20%. So, as you all know, the total iron we're taking daily may be around 15, 12 to 18 milligram, but only 1 milligram iron comes inside our body. The iron which are taken inside the body or keeps inside the body are divided in two sections. One is storage iron, other one is functional iron. And how much iron do we have in total? 3 to 5 gram. This is a very small amount, and about 1 gram iron is in the storage situation. So, how iron deficiency happens in the patients? There is three main sources: reduced iron intake, increased iron losses, and inflammation, which reduce iron mobilization. So we have to find out a biomarker, how to identify the iron deficiency in patients. So we already have mentioned that we have two sources of iron in the body. One is utilized iron and functional iron, other is stored iron. Stored iron, we can identify it by ferritin in the peripheral blood, and for utilized iron or functional iron, the TSAT score can be used. And in medicine, several chronic conditions can give rise to iron deficiency. Among these conditions, chronic heart failure has a specific criteria for diagnosis of iron deficiency. These are some tests which in alone cannot identify or cannot be used as a marker of iron deficiency. But when used together, especially the first four, are quite important in identifying the iron deficiency anemia or iron deficiency in humans. That is the serum iron, serum ferritin, transferrin, and transferrin saturation. So, potential cause of iron deficiency in heart failure. These are, we should have to understand, the reduced iron storage. It comes due to malnutrition, malabsorption, GI blood losses, which ultimately gives rise to absolute iron deficiency in patients. In other places, there might be functional iron deficiency, which is due to inflammation, due to blunted response to erythropoietin, apoptosis or erythroid designation, and hepcidin recognition. So there is reduced iron mobilization, and in this case, there is functional deficiency of iron. So iron deficiency, is it common in heart failure patients? Yes, it is common. Several studies have shown that there are 50% patients, they have iron deficiency anemia, maybe without anemia or with anemia. And there is always some studies shows that with iron deficiency, there is poor outcome also in case of acute heart failure patients in response to their lengthy stay, mortality, and heart failure readmission. Iron deficiency associated with poor outcome. In the study by iron deficiency, there is shown that patients without iron deficiency has a better outcome than poor iron deficiency status. So, what is the cause of iron deficiency in those group of patients? There is dual effect of iron deficiency. First of all, defective oxygen delivery. In case of iron deficiency patient, oxygen capacity of hemoglobin is reduced and oxygen delivery is poor. On the other hand, defective oxygen metabolism causes iron deficiency and oxygen storage reduced and tissue oxygen capacity also reduced. And ultimately, the oxygen utilization is reduced and overall effect is lesser or lower maximum oxygen utilization. The impact of iron deficiency in heart failure, there are impact in three levels: cellular, tissue, and physiological level. Cellular, mitochondrial dysfunction, deranged enzymatic activity, and abnormal transport and structural proteins. Tissue remodeling, abnormal impaired oxygen efficacy and reduced oxygen, and physiological impaired exercise capacity, reduced work efficiency, and others. And as a whole, if you look for prevalence of iron deficiency, different studies have shown around from 42% to around 50% iron deficiency in different scenarios. As a whole, in case of acute heart failure, the iron deficiency as an average is around 50%. But when the ESC guideline is considered, it shows that iron deficiency, which can be present independently of the anemia, is present in 55% of patient of the chronic heart failure patients and 80% with acute heart failure. Iron in heart failure, if you give these patients iron, IV iron improves function of the cardiomyocyte, IV iron improves performance of the skeletal muscles. And there are several studies ongoing. Among the studies, iron out studies have proven that there is limited evidence that supporting that use of oral iron preparation in the treatment of iron deficiency helps. It doesn't help at all. So the use of oral iron is not advocated in pattern. But on the other hand, the fair heart failure trial, in contrast to iron out stout, has shown definitely that IV iron is always a better option for treating patients with iron deficiency. And there is a large meta-analysis that's shown that in heart failure hospitalization patient and cardiovascular death, uh, the patients studies needed to studies have shown that the ferric carboxymaltose has been efficacious in treating patients with iron deficiency. And clinical implication uh, in heart failure patients treated with iron deficiency with iron or IV iron, it improves the overall condition of the patient. And different meta-analysis as a whole shown that IV iron is better than other options. And iron can be used in the all stages of heart failure patients from beginning to death, also in case of acute heart failure also. And what are the ESC guidelines changed? ESC guidelines are updated from 2016-13 and ultimately 2020 focus update. The focus update has said that intravenous iron supplement is recommended in symptomatic patients with heart failure reduced infection, hydrofailure with moderately reduced infection, and intravenous iron supplementation with ferric carboxymaltose and ferric deoxymaltose should be considered in symptomatic patients.
Thank you.